Hi, I'm Dr. Molly Hoybline. Welcome to the Curbsiders Teach, the Curbsiders Family Podcast on teaching in medicine.
And I'm Dr. Ira Krzyzanowska. We're excited to recap one of our favorite episodes from Curbsiders Teach Season 2, Precepting Potpourri with Drs. Alika Ray and Ryan Nutt.
This was such a fun episode, and I got a lot of great pearls out of it. We review 4 different approaches to precepting in the clinical setting: the traditional precepting model, the 1-minute preceptor, SNAPs, and precepting in the presence of the patient. I love this episode because as an outpatient academic internist, I do a lot of precepting in clinic, and hearing more approaches is always really helpful. Let's set the stage with thinking about the traditional precepting model. Ira, could you describe what that looks like and when you might use it?
You got it, Molly. The traditional model is one that many of us are familiar with. Perhaps it's even what we do for many precepting encounters. The traditional model focuses on clinical supervision, making sure to provide the safest care for the patient. The learner presents information to the preceptor asks for additional details, and then gives a plan to the learner to implement, as opposed to asking for their well-reasoned plan. Often there's no deliberate teaching. If teaching does occur, it is usually specific to the patient case and not really generalizable to future patient care. Typically, there's no direct feedback given to the learner. Indirect feedback is provided as the preceptor does make changes to a care plan or present their care plan. And this model is typically time efficient for patient care. However, it does not allow the preceptor to assess the learner's knowledge or their clinical reasoning skills. And while many of us are familiar with this approach, our Teach episode walks us through a few other approaches for precepting to consider. Molly, do you want to explain the 1-minute preceptor approach?
I would love to, Ira. This is the first one that I was exposed to as a clinician educator, and I think it's just a really great one because it's so simple, but also so practical and can really help up your teaching if you don't feel confident with just sort of jumping into it without a framework. So the 1-minute preceptor focuses on 5 micro skills. Number 1, get a commitment. 2, probe for supporting evidence. 3, teach a general principle. 4, reinforce what went well. And 5, correct errors and omissions. So in the first step, getting a commitment, that can be either a diagnosis or a next step in management. So you really need to ask the learner, what is the working diagnosis? If it's a clear diagnosis that's already established, what's the next step in treatment? Getting them to really put down their money, decide what they want to suggest, and commit to it. And then step 2, you want to probe for supporting evidence. So that's asking the learner questions about where they got to that point, where they got to that commitment, and what kinds of things support or discourage other clinical diagnoses. And the goal here is to understand the learner's thought process and clinical reasoning so that you can really help them learn and grow. That moves us on to step 3, which is teach a general principle. So really a short, succinct teaching pearl that the learner can apply to future patient care. We're really busy in the outpatient setting. Just a really quick pearl is all the learner's really able to take in and continue to carry forward after this. Step 4 is reinforce what went well. So encouraging those, correct thinking patterns, those illness scripts that are spot on. And then 5 is correct errors and omissions. And be mindful about the space in which you're providing critical feedback. So it may be best to save this for a one-on-one session and not in a crowded room. And for more advanced learners without really errors in their presentation, you could ask about other differential diagnoses as a thought exercise to avoid anchoring. So kind of saying, what if the situation were a little bit different? Where would you take this?
I love that, Molly. Thank you for that super in-depth review. And I actually really like to use the 1-minute preceptor model in precepting situations with early learners. It really tends to be focused on making the diagnosis and what went into that process for the learner. So I like that we get to pause and have a discussion around kind of the showing of the work, or really how learners got to a particular diagnosis, what they considered, and what else went into their kind of consideration, that thought process.
Great. So that was 1-minute preceptor. Let's talk about SNAPs. So SNAPPS is summarize the patient case, narrow the differential to narrow the differential to 2 or 3 possibilities, analyze the differential by comparing and contrasting the different possibilities, probe the preceptor about uncertainties, difficulties, or challenges with the patient case, plan management, and select a case-related issue for self-directed learning. So SNAPS is a great learner-driven approach, and it's really best in that sense for more advanced learners who can self-assess knowledge gaps. It forces the learner to identify the knowledge gap as a self-directed study at the end of this model, which is a really key component of this strategy. I think this is a great one for learners that maybe work with preceptors that are more tied to that traditional model and maybe need to push the preceptor to help them learn a little bit more.
Thanks, Molly. I have deep thoughts about the SNAPS model, but truly I do like it. And I like that it gives a chance for the learner to do more self-directed learning and self-directed assessment. So let's move on to our final model, precepting, the PIPP, or precepting in the presence of the patient. This is the outpatient equivalent of inpatient bedside presentations. So a learner sees and examines the patient as per usual, and then when the learner is ready, the preceptor joins them in the exam room. So the presentation actually occurs in front of the patient, at which time the preceptor can ask clarifying questions, perform any additional exam maneuvers, review the plan with the patient and the learner. And that time, the preceptor can also add teaching pearls in the exam room and, if necessary, debrief with the learner after the encounter. This model is efficient. It is patient-centered. PIPP increases the time face-to-face with the patient and can actually reduce the patient's length of time in the office. This model works really well for early and advanced learners. It also allows the preceptor more time to observe the learner, especially in the exam room, and to provide feedback, have that feedback conversation on the communication style, the body language, the use of the electronic health record, and other aspects of doctoring that are often not observed if you're receiving the presentation outside of the exam. There are challenges, of course, to this precepting model, and that includes making learners feel comfortable presenting in front of the patient and ensuring that patients allow the learners to direct and lead the encounter, as opposed to sometimes what might happen where the patient just directs all their attention to the preceptor.
I have tried the PIPP model when we're running behind and just need to catch up a little bit on time. And I think in that sense, it can work really well to save time for the patient. I mean, I know sometimes our patients are waiting for an hour to see the resident, and just anything that can improve in efficiency for the residents is great. Um, so I would say, each of these precepting models, the 1 minute preceptor, SNAPS, PIPP, they really allow the preceptor to assess the learner's thought process and clinical reasoning. And that's just so key in our role as educators to be able to encourage our learners to grow and see sort of where their learning edge is. Because with the traditional model, we really don't have a lot of sense of actually how much skill and knowledge they carry. And maybe we're teaching something that they already know, and maybe we're not guiding them in the way that they need. One thing that all of these models have in common is deliberate practice and intention. As long as you're deliberate and intentional, you can choose any precepting model or aspect of one of these models and make it work for you. You don't have to go through all 5 steps. You could just pick 2 and focus on those. And there have been outcome studies from these different approaches. The 1 minute preceptor seems to be more focused on differentials and diagnostic evaluation as compared to the traditional model, which is more focused on history taking, risk factors, and presentation skills. The SNAPS model is more likely to explore differentials and justification for those as compared to the traditional model. So we have good data that these precepting approaches really do change the information that we hear from our learners.
And just to add a few tips on teaching pearls, we often teach around differentials and medical knowledge, but you can, as the preceptor, also go into areas of management reasoning. And actually, shout out to our Curbsiders Teach Season 1 episode on this if you want more. But this is a chance for the preceptor to teach about processes. Some residents are super solid on their medical knowledge, but they have gaps around how do I get things done? So this teaching on management reasoning can be generalizable and will empower residents, especially if that's who you're teaching, to take better care of their patients. And this is kind of the getting stuff done reasoning that is part of being a physician and part of excelling in systems-based practice. With advanced learners, it can also be helpful to push their thinking with hypotheticals, as Molly mentioned earlier. So if someone is hitting the nail on the head with their presentation, maybe asking again, what would you do if this patient had XYZ? Or why wouldn't this other medication work well in this situation?
So we had a great conversation also about continuous improvement as a preceptor. One pearl that I loved from Drs. Ray and Null was that to really help improve feedback conversations with learners, It can be very helpful to have the attending start off by sharing something that the attending themselves feel like they didn't do well or that they're trying to improve upon, to allow the learners to feel comfortable sharing things that they feel like maybe the attending could work on. By doing this, it can really, help us get the feedback that we need to improve our skills. It can also be really helpful to get your peers to kind of sit and watch you, or watch your peers to learn new approaches to teaching in clinic. So if you want to hear the full episode, click on the link in the transcript. You can see our show notes and graphics there as well. I've been Dr. Molly Hoivline.
And I'm Dr. Ira Krzyzanowska. Thanks so much for joining us on this quick refresher of our Precepting Potpourri episode with Drs. Nall and Ray.